morning, everybody. So welcome to our weekly virtual medical grand rounds. Today, I am delighted to introduce Dr. Richard Lewanczuk, who's going to be speaking on the challenges of managing chronic disease in the era of COVID. So Dr. Lewanczuk is a professor in the Division of Endocrinology. He received his MD as well as specialty certification in internal medicine and endocrinology at the University of Alberta. He holds a PhD in medical sciences and medicine. His current role is as Senior Medical Director for Health Systems Integration, which is Alberta Health Services' long-term vision for integration within the healthcare system, as well as across sectors which determine health in general, such as volunteer sector, other government ministries, municipalities, and business, all with the goal of keeping people as healthy, well, and independent as they can be in their homes and communities. To that end, Dr. Lewanczuk has been involved with chronic disease management and prevention for most of his career and has contributed to many national and international bodies and initiatives which addressed either specific chronic disease in general, or health system integration. So we felt that this was extremely timely, given that we've now into our relaunch phase and we know that these patients are most vulnerable. So without further ado, I'll hand it over to Dr. Lewanczuk.
Thank you very much, Narman, and very grateful for the opportunity to present this morning on the challenges of managing chronic diseases in the era of COVID. As you probably are all aware, we talk about the waves of COVID, not around the recovery, but the actual waves of COVID applies to any pandemic. And in those waves, the first wave is that occurs as a result of the actual disease. So in other words, COVID. So what is the impact on the healthcare system of COVID infection, hospitalizations, of ICU use? But then there's a so-called second wave, which is partially the topic of what we're going to address, which is those people with acute conditions who stayed away from hospital or medical care for various reasons, or whom we couldn't bring into the healthcare system for capacity reasons. But then the majority of what we're going to talk about is a so-called third wave. And those are people with chronic conditions who have not been able to access, again, for various reasons, the healthcare system. And what is the impact on them and on us? And then just to complete the picture, there's the fourth wave, which is the long-term impact on the population in general, but also on ourselves. So this scheme isn't something that is conceptual or theoretical, but this actually comes from experience with conditions like SARS or H1N1. And the fourth wave then is the impact on frontline providers, the economic impact, the long-term impacts of conditions like COVID. So in this talk, I've arranged it a little bit along the past, the present, and the future, because as we're starting to come out of the hyperacute or acute phase of COVID, things are changing a little bit, but there have been a lot of challenges, as many of you have run across, in managing people with chronic disease in the past few weeks. There are current challenges, and there are going to be challenges in the future, although there are also going to be opportunities in the future from our learnings. So to be a little bit more explicit, I'm going to talk a little bit about what have the challenges been of managing people with chronic disease during a serious pandemic like COVID and without face-to-face contact. What are the challenges of managing people with chronic disease now, and what will the challenges and opportunities be in the future? So let's get going. Well, this is a little bit of the outline of what's gone on in the past and our challenges in the past. The first thing I want to talk about is the whole personal component of dealing with people without face-to-face contact. You might think that this is the least important, or this should be at the bottom of the list, but maybe let's reconsider that. So we know that in the time of COVID, we haven't been able to see people face-to-face in outpatient clinics. People haven't been coming to primary care, and so our face-to-face contact has been decreased. And one of the things that I think we all know from Psychology 101 is that a lot of communication is nonverbal. And the physician-patient relationship, our dealing with patients, is all about relationships and about communication, getting the appropriate information. And so by not being able to have face-to-face contact, we immediately eliminate somewhere like 55% of that nonverbal communication, the nonverbal clues as to how people are doing, what they're thinking. I don't have to tell you anything, and you don't have to hear any words from these three people to have some sense of what they're feeling or what they're thinking. And that just exemplifies how we get and pick up on nonverbal communication. So as I said, the physician-patient relationship is a relationship. It depends often on face-to-face contact, on those nonverbal cues. And we're going to talk a bit more about this. Well, the next slide, touch, seems perhaps out of place. It's too bad that these rounds weren't in classroom D or that I couldn't see you, because right now I would ask you, how many of you were taught in your medical training to touch the patient? Because I was always taught by, our eminent predecessors, Alan Gilbert or Buzz Edwards, always touch the patient. I was quite dismayed recently to learn that some faculties of nursing in the province are teaching their students to not touch the patient, only touch when necessary and with gloves, and only when, for example, you're giving medication. Our pediatric emergency physicians are taught don't touch the patients unless absolutely necessary. Which is flying in the face of what's shown on this slide here, which is actual scientific evidence on the benefits of human touch. And so that's one of the things that we often don't even think about in the face-to-face medical encounter. But I was taught touch the patient. It turns out that patients appreciate that face-to-face encounter. They appreciate the hand on the shoulder, the pat on the back of the hand. They find touch and face-to-face contact actually as comforting. Turns out there is science around face-to-face in-person contact. We know that just face-to-face contact releases a whole host of neurotransmitters and hormones that have benefit, and touch just adds to that. And there's a lot of references around that. But I just want to highlight one little anecdote that I ran across in COVID around chronic disease management. This is a 30-year-old fellow with Crohn's disease. And of course, Crohn's chronic condition. And with COVID, what's the first thing we did? Well, we stopped medical outpatient sorts of drug infusions. He wasn't at this hospital, at the university hospital. He was somewhere else. So he didn't get his Remicade. And of course, what happened? Well, his Crohn's got worse. He developed a lot of pain, blood in his stool again, lost his appetite, losing weight, just wasn't doing well at all from his Crohn's perspective. And then he got a rash. A whole body rash. And this is a fellow, he worked in one of these jobs where it's a lot of guys, in that macho sort of setting. And they started teasing him, hey, or what are you doing? You using crystal meth? Has that sort of crystal meth type of rash. So it was causing a lot of psychological trauma. He had 4 children, a wife, and of course, all of the COVID stresses. So he was under a ton of stress. Well, what did he do? Go see the family doctor. Well, the family doctor's office is closed. So he went to the emergency department. Well, you've got a rash. That's not an emergency. What should I do? Go see your family doctor. So he was beside himself. He's got losing weight, blood in his stool, abdominal pain, all sorts of stresses, psychological stresses, emotional stresses. And when I encountered him one morning, he just said, that's it. I'm just going to end it all. So this 30-year-old fellow, he was in absolute tears. And what was he saying? He's saying, I just want to see a doctor. Why can't I see a doctor? So that's some of the impact on chronic disease management that COVID led to us. Well, paradoxically, it turns out it affects us as well as physicians, nurses, care providers. That turns out that face-to-face communication has also a benefit to us. It gives us satisfaction when we can see our patients. So that's been one of the impacts in managing chronic disease with COVID. Another one, this is fairly obvious, is we can't examine patients. We've had reduced access to lab and diagnostic imaging. And so this is a little bit what we were trying to manage people during COVID. I can tell you as an endocrinologist, pretty hard to manage somebody with hyperthyroidism when you have no access to their thyroid function tests. And we were routinely having our patients turned down for their thyroid function tests. So I won't say more about that, but this has been one of the challenges in the past pandemic and in any future pandemics if we have limited access to the appropriate information. Another challenge has been that our patients have stayed away, and patients with chronic disease have stayed away from medical care, whether it's from fear or from other priorities or because of their mental health. We actually know that people with coronary artery disease and cardiovascular disease, there was a reduction of somewhere between 25 to 40% attendance in emergency departments for coronary related issues. And we know that it wasn't because there were less coronary related issues, because people, for example, with cerebrovascular issues, which are very obvious to people, still had the same attendance. Another challenge is that, of course, during COVID, people with chronic disease had other priorities. People were losing their jobs. They were afraid. They had other social stresses. And of course, you know, when you've lost your job, you don't know if you're going to lose your job. You don't know if you're going to be able to pay your mortgage, pay your rent, feed your family, have access to food. The last thing in the world you could care about is what your hemoglobin A1C or your LDL level is. So as has been said, you know, health, you know, a long-term gain or goal, I should say, is not really a priority when you don't know whether you can meet your rent payment tomorrow or put food on your table tonight. Another challenge, of course, has been a lot of our patients with chronic disease depend on, you know, non-pharmacological treatment, on wellness, things like physical activity, walking, exercise, access to a healthy diet and food. And all of those opportunities have been reduced during COVID. So our social connections, which we'll talk a lot more about in a moment, were reduced. Opportunities for physical activity became almost non-existent. Couldn't go to the gym, couldn't go to the fitness center, you know, had to maintain social distancing. Remember, at the beginning of COVID, this was still, you know, early March when there was ice on sidewalks, it was cold, it was windy, there were snowstorms. People couldn't maintain their activity levels that they were used to. And of course, has an impact on chronic conditions. Food choices actually went down. For those of us on this call, we might be thinking, well, what are you talking about? You know, if I couldn't find what I needed in Superstore, I could go to Safeway or I could go to Save on Foods. Well, if you're, you know, a senior and you're dependent on a ride to get to the grocery store, you know, what you see is what you get. You have your one opportunity to fill your grocery cart. And if something that you're used to eating isn't there, well, then you had to do without. And particularly for seniors who were dependent on some regular form of activity, where we had them, you know, locked up, barricaded behind closed doors, a lot of deconditioning and loss of physical abilities and muscle strength, increased falls, increased imbalance. So significant impact that way. The other thing that happened is there's reduced community supports. First thing we did right at the beginning of COVID is we stopped all what we thought non-essential standard type of home care. Things like ensuring people were taking their pills, homemaking, a lot of those very, very vital functions that we didn't think were so vital. A lot of supports provided by volunteers were reduced. So driving our transportation opportunities. We had a big challenge with people, for example, getting to chemotherapy, radiation therapy, or getting to appointments to manage their chronic disease because our volunteer supports, they had challenges with providing service. Municipal supports like transportation, of course, we've heard all about that in terms of the buses, and LRT was decreased. But again, our recreation centers were closed down. Programs were closed down for seniors and others. The senior centers where people got socialization or activity, again, all closed down, all had an impact on our managing people with chronic disease. But this next area is one that I want to spend a bit of time on because it's one that has, I think, been hidden from a lot of us. It's one of these areas where it was sort of the necessary evil. And one area that I think we just didn't appreciate or didn't even particularly acknowledge. Not that we could do anything about it, but even just that acknowledgement. And as that is the effect of COVID and the stress of COVID on the mind, on the body, and in terms of the emotions. How many times have we heard this said? We're all in this together. Every single TV, radio commercial, politician, all we ever heard is we're all in this together. We're all in this together. I would say nonsense. We were all in this alone, maybe together alone, but we were all in this alone. We had to retreat into our houses, particularly if you were vulnerable. You know, retreat into your house, pull up the drawbridge, bar the doors, and for gosh sakes, you know, don't have any public contact. We were all isolated because of COVID. So our social distancing, well, what's social distancing lead to? Well, social distancing basically led to social isolation. And of course, what does social isolation lead to? It leads to loneliness. Well, just very quickly, definition, social isolation is a lack of social relationships and contact. Loneliness is the unpleasant feeling that comes from a lack of social relationships and contact. But you know what? Turns out that the social isolation and loneliness has had a significant impact on people's mental health and mental well-being. There have been 2 national surveys that have been carried out in Canada regarding this, and these surveys basically show the following, that the majority of our population has had mental health effects of loneliness and social isolation. And this is not unique. The same thing has come out of China, of northern Spain, and out of Italy, where they've done these surveys. And this isn't just emotional, oh, I'm feeling lonely. This is actual true mental health impacts. I was talking to our AHS head of addictions and mental health yesterday, in fact, and he said that they are swamped right now with mental health issues. Turns out our mental health beds, inpatient beds, are also full with these issues. And our learnings from, for example, Fort McMurray fires tell us that this is a significant impact, and it's going to be a long-term impact. Well, we've socially isolated people, and one of the things that we know is social isolation, even in the absence of loneliness, is bad for you. We are social creatures as humans, and we do need that social contact. And I could show you any number of studies, but this is just one example that says basically the more socially isolated you are, the higher the mortality, population mortality is. Many, many studies showing social isolation is bad in terms of physical health, not just mental health, but physical health. Remember, we said earlier on that one of the effects of COVID was that people didn't show up for appointments. Well, it turns out that when you're lonely, you won't show up for appointments. So are people with chronic disease, with their diabetes, hypertension, inflammatory bowel disease, COPD, arthritis, what have you, just didn't show up. They were socially isolated, lonely, couldn't care. They were demotivated to look after themselves. It's been said, actually very good estimates, that when you're socially isolated, it's the equivalent of smoking half a pack of cigarettes per day. So we socially isolated people. Could you ever see ourselves telling people, we want you to smoke half a pack of cigarettes per day? Another way of putting it, it has the same physical impact as if we had given all of these people type 2 diabetes. So significant physical effects. Well, I wanted to show you this slide. This is all evidence-based. This is what chronic conditions has loneliness been causally associated with. And you'll see on this list, hypertension, diabetes, depression, cardiovascular disease, so on and so forth. But some of you, if you remember the last Grand Rounds that Norman and I co-presented, may twig a memory, hypertension, diabetes, depression. What's familiar about that? Well, it turns out that hypertension, diabetes, depression are the 3 most costly chronic conditions in Alberta in rank order. Turns out that they're the most costly chronic conditions in Canada, North America, and the world. What is it that loneliness leads to? Hypertension, diabetes, depression, all causally linked. So again, another impact on chronic disease of COVID are social distancing, social isolation, and loneliness. So you'll remember this handsome fellow that gave Grand Rounds a few weeks ago, Dr. Daryl Ralston, and he talked to us about elderly, frailty, and he pointed out that as we get older, our physiological reserves tend to decrease, and that the difference of being pre-frail and frail was our reserve, our resilience that we had. So what is it that leads to our resilience or coping mechanisms in older people, particularly around social isolation. So he taught us that as you lose this physiological reserve and all of a sudden an acute event occurs, like all of a sudden you're socially isolated and lonely, how do you cope? What are your coping mechanisms? Well, here's the coping mechanism. In other words, the treatment for loneliness and social isolation. This is what patients tell us. They said, well, what I do is I just simply sit with someone. That's all I need to do. Nah, can't do that with COVID. Sorry, can't sit with someone. Laughing with someone. Well, you could do that. You can call the joke line. I'll give you that. What else? Getting a hug. Sorry, can't do that with COVID. Having a holiday. Sorry, can't do that with COVID. Sharing a meal. Sorry, can't do that with COVID. Going for a walk. Well, as long as it's 2 meters apart and the weather's nice. Holding hands. So most of our coping mechanisms and our capacity for resiliency was taken away by social isolation. But it gets even worse. I mentioned physical effects. We know that social isolation has physical effects. Our current, theory of disease, and those residents that have been on my team over the years know about my grand theory of everything. What we're understanding about this impact of low-level inflammation caused by visceral obesity or your chronic inflammatory chronic disease, leading to things like diabetes, hypertension, cardiovascular disease, cancer. And what does loneliness and social isolation do? Well, you can see on this slide, the lower your social isolation or the higher your social integration, the lower your inflammatory markers. The greater your social isolation, the higher your inflammatory markers, the higher your blood pressure, the greater your weight gain, the greater your chance of developing type 2 diabetes. You don't have to know anything about genetics to be able to interpret this gene chip. This is about 220 people who were divided into lonely or not lonely, and then they looked at gene expression, and you can see a huge number of genes that are differentially expressed as a result of loneliness and social isolation. The worrisome thing is that in prospective studies where they basically simulated social isolation, put people, for example, in the equivalent of solitary confinement for a month, is that not all of these physical and physiological changes went back to normal after social isolation. 1 month of social isolation, we understand, can have a permanent physical impact on people's health such that they become more prone to chronic disease or their chronic disease is not managed as well. Well, earlier on, we said face-to-face contact, touch, all of those sorts of things has an impact. Well, what does it actually do? We can actually measure physiological neuroendocrine effects of face-to-face contact and human touch. It has impacts on cortisol, DHEAS, the most abundant hormone in our body. Here's some trivia I always ask our residents. Most abundant hormone in our body, DHEAS, 100 times more DHEAS than any other hormone. We don't have a clue what it does other than when you feel well and are socially well, DHEAS levels go up. Social isolation goes down. Oxytocin, the wellness hormone, the love hormone, immediately goes up when you shake hands, when you touch a person, when you see somebody that you have a relationship with face to face. Serotonin, dopamine, norepinephrine, all the neurotransmitters related to mood, all affected by face to face and contact and human touch. Benefits of hugging. Sorry, I stuck this in here. You might think, why is this is sort of out of place? Remember, we couldn't hug. All sorts of physiological benefits from hugging. Why on earth am I bringing that up? It's because of this following slide. One of the things we also know that loneliness affects is the immune system. So in this slide, and I could show you any number of other studies, is that when you're lonely, socially isolated, it has an adverse effect on the immune system. So in this case, it showed that latent herpes virus, CMV infections no longer became latent, but became overt in lonely people. But that just leads up to the following study that I think is very germane. This study was done in Sweden. They took 404 people and they divided them into 2 groups. They divided them into people who got a lot of hugs and people who did not get a lot of hugs. Then they tracked this group for a month. They looked at their stress or days of tension. And then, believe it or not, they actually exposed them to one of the cold viruses. So they actually tried to give them colds and they looked what happened. So remember, we say that stress makes you more prone to infection. Well, it actually does. The more stress, the more likely people were to actually become infected with the cold. But there's a caveat to that. That's only if you did not get hugs. If you got hugs, you were much less likely to get a cold. Well, they then redivided the group in terms of hugs just to your social supports. So if you had strong social supports, much less likely to become infected. Didn't have strong social supports, in other words, social isolation, loneliness, more likely to get infected. So here we are with a viral infection, COVID-19. We're trying to protect people. And in fact, our treatment actually makes them more prone to infection. Now, I'm not saying that we shouldn't have had social isolation, but just this appreciation of what the impacts have been on our patients, particularly now add in chronic disease where we know they were more prone to infection, just to understand what we did. Well, we're sort of halfway through-ish, or a little bit more than halfway through, so I just wanted to put in the slide here. You can see all these athletes touching each other, baseball players, hockey players, basketball, football. We all seen it watching TV. The guy, scores a goal in the NHL, goes past the bench, touches everybody. Have you ever asked yourself, why is that? Is that just, good team spirit? It actually turns out that they are required to touch each other. I never knew this until a friend of mine is the coach of the U of A Pandas basketball team. The members of the team, they are instructed to touch each other frequently because of everything that I've just said, the physical benefit, the mental benefit. They actually have a person sitting in the stands who records how many times each player touches another player. And if you do not touch your co-teammates enough, you're called to the coach's office and said, hey, you know what? Need to be touching more. So it actually has benefit. Well, if you can't touch in the era of COVID, what can you do? Well, you know what? The teddy bear actually has an effect. Have you ever wondered why they collect stuffed animals for the Stollery Hospital? It's because if you can't touch a human, there actually is a surrogate benefit from having your little teddy and squeezing that. And I've said in the era of COVID, and that's why pet ownership, you'll also remember in the grand rounds that Norman and I gave about a year ago, we talked about the health benefits of pet ownership. Well, if you can't have a pet, and by the way, of course, pet ownership and adoptions from the SPCA went up, skyrocketed during COVID, you can at least give somebody a plant, for example, something to look after. So I'm just going to end this section by saying, to sum it all up, we know that social isolation, loneliness has a significant impact on physical, mental health. It's a long-lasting impact. We know that, it says here, Medicare spends more because our medical care costs go up. That's been some of the challenges of trying to manage people with chronic disease during COVID. Well, what about now? How does that translate now where we're starting to open up our outpatient clinics? We're starting to see people again. What can we expect? Well, the first thing that we can expect, I think we can guess this, and if we guess this, you're right, is that over time, what did we say? People didn't show up. We couldn't see people, or they didn't come to see us. People stayed away or were kept away. You know, the fellow with the Crohn's disease where we didn't give him his Remicade. What happened? Well, the experience from SARS in Ontario tells us that there is this tidal wave of people who are going to be lined up at the door, hopefully socially distanced, to see us. So there's going to be a huge increase in volume. And of course, the problem is that without management and control of the chronic disease, the chronic diseases are going to be worse. So this young man that I told you about, whose Crohn's disease was controlled, now, as you can imagine, it's way out of control. He's got this additional problem. He's got the mental health problems, emotional problems. It's going to be a lot tougher to look after our people whose diabetes is out of control, whose hypertension is out of control, whose asthma is being affected, you know, so on and so forth. This was the experience with SARS in Ontario. Now, hopefully, we're really hopeful that this may be mitigated a little bit. A recent survey from the College of Family Physicians said that 79% of family doctors were aware of their people with chronic disease, and we're trying to mitigate the impact of the chronic diseases during COVID. So we'll just have to wait and see. But if SARS was telltale, we could expect more people lined up with worsened clinical status. Everything I said about the social stresses, the mental stresses, and the financial stresses still is going to be present. As we heard, you maybe 290,000 more jobs, but there's still 3 million people who lost their jobs. Still lots of financial stress, mental stress, and social stress still ongoing from COVID. To put that in perspective, in the financial crash of 2008, if you look at changes in enjoyment, worry, and stress, enjoyment didn't really change. Worry went up a little bit, stress went up a little bit, but look at what COVID has done. Huge reduction in people's enjoyment in life, huge increase in worry, huge increase in stress, and we just said the impacts of that worry and stress on mental and physical health. We're all aware of the financial impacts. We hear that all the time on the news. Well, this is what our patients are telling us. Changes to chronic disease management as a result of COVID. So first statement, my stress levels have made my condition worse. Almost half of our patients have said that. My diabetes is worse, my hypertension is worse, my inflammatory bowel disease is worse, my arthritis is worse because of the stress of COVID. And you can go down this list. Anxiety and depression is leading to high levels of stress. I'm scared to leave the house to go to see the doctor. What did we say? Patients were staying away. Not even going to the pharmacy. A lot of reduction in people filling their prescriptions. My appointments have been canceled, so on and so forth. This is a map of Edmonton. This highlights our complex high needs patients. So these are patients with 3 or more chronic conditions, for example, or frail older adults who have a lot of health problems. This is another map of Edmonton showing diabetes prevalence, but I could take away diabetes and substitute hypertension, coronary artery disease, heart failure, COPD, any chronic disease, and it would superimpose. And yet in the top left, here's yet another geospatial map of Edmonton showing material deprivation or low income or income issues. And you can see total overlap. So financial stresses overlap with chronic disease, overlap with high healthcare utilization. And what does this tell us? Well, we know that there's an increase in chronic disease incidence and prevalence in people with low income or who are experiencing financial stress. What has COVID done? Causes financial stress having an impact on chronic disease. So I wanted to show you this study that we published a few years ago. And in this case, rather than just putting the reference, I put the actual face page from the publication there because there's a lot of famous people involved with this, this study. People like Braden Mans, who's now our head of the Strategic Clinical Networks in Alberta. This person here, Brenda Hemmelgarn, whose name may be familiar to you as our new Dean of Medicine, was on this study. Yours truly, Dr. Ted Braun, who is one of the vice presidents of operations for Alberta Health Services. And in this study, we looked at the factors that determine diabetes control. And we started out with a study taking medical administrative data and saying, can we predict whose diabetes will not be well controlled? And it turned out that we could not predict using medical administrative data who and who would not have their diabetes controlled. And then we had the brilliant idea of maybe we should throw in some social data. The minute we threw in social data, all became clear. The lowest income pentile in this case, or quintile, had the poorest diabetes control or the highest chance of not being under control. And it turns out that we should have known this. There's many, many studies showing that there's a strong linkage between chronic disease control and social factors. Same thing in this slide for hypertension. Poor income, low income, and less likelihood of hypertension control. Any chronic disease, much less likely to be controlled if social factors get in the way. And so you'll recall, we're now paying attention to social factors and saying we have to be able to deal with these in order to control chronic disease. And that's been the problem with COVID. We've introduced a whole host of social factors, loneliness, income issues, food insecurity, and we can anticipate now and on an ongoing basis, that this is going to have an impact on chronic disease status and chronic disease management. This is just a slide to show you impact of food insecurity, for example, on chronic disease. And you'll recognize some common players in here: greater chance of hypertension, greater chance of diabetes, greater chance of depression. Do those chronic diseases sound familiar? Just to finish up this part as well, this looks really airy-fairy now. Meaning in life. You know, what is the meaning in life? Well, it turns out there's a correlation between meaning in life and your physical health, your mental health, and your cognitive functioning. And basically what this says is that if you have no meaning in life, no happiness, it's going to have an impact on your physical health and obviously your mental health. Well, what do we need for meaning in life, or what do we need for happiness? Well, it requires three things. It requires something to do, someone to love. Interestingly, not someone to love you, but you to love someone, and something to look forward to. What did we do in COVID? Well, we took away the something to do. You got to stay barricaded in your house with nothing to do. Something to look forward to. Well, can't go on a holiday, can't interact with people, can't go to a restaurant, can't go to a concert, nothing to look forward to. Someone to love. And you have to have that face-to-face contact and those relationships to effectively have that sort of thing. So again, this impact on people's lives. So, you know, sometimes, you know, is the treatment worse than the cure? Well, of course we have had to have social isolation, but the experts tell us it's a necessary thing that we have to do, but only as long as we for as long as is absolutely necessary, and that there is going to be a psychological impact. Well, just to finish up, what are the current challenges of managing people with chronic disease? Well, not only backlog to see us and see their family doctor or primary care provider, but there's a backlog, of course, for diagnostic imaging. There's now a backlog for consultations, backlog for surgery, and we're going to have to be dealing with this, as we've heard, for the next number of months, if not years. And guess what? Same thing that has had an impact previously and in past is having a current impact. There currently are, and for the next little while, are going to be reduced social supports. A lot of our volunteer agencies are just like businesses. They've been impacted by COVID, and a lot of the volunteer groups have basically gone out of business. We may not have their supports available. Home care is still not up to full speed. A lot of the support programs that people are used to are still not back up to speed. So there's going to be a challenge there in managing people. Well, let's move on to the future then. How is this going to impact us in managing chronic disease in the future? Well, one of the challenges is that, remember we said that impact of pandemic or a lot of the stress on people may be permanent. Higher chances of chronic disease, poorer control on a long-term basis. And the studies have shown us that this, as far as we know, can go on for years for any sort of major psychosocial, physiological type of stress. So we're going to have the impact of COVID on physical health, on mental health for months, if not years to come. The financial challenges, which we've heard, are going to take years potentially to resolve. Turns out studies tell us that 1% increase in unemployment correlates with a 2% increase in chronic disease incidence. Greater incidence of arthritis, back pain, cardiovascular disease, asthma, mental health, diabetes should be in there as well. People worrying about their jobs, their income, everything else, physical health may not be their priority. When, as I said, when you have other things to worry about right now, whether you can pay your mortgage or not, you could care less what your LDL and 10-year Framingham risk is. Government has spent a lot of money in COVID, and we are already being signaled that the government support programs are going to be reduced in future. So our social stresses are going to increase, and we're not going to have those supports there. And there's going to be that ongoing impact on volunteer groups whose function, some of them may not be there in the future, or their function may be reduced. But not to be totally negative, because it's been a lot of doom and gloom. I realize that the one thing that is coming out of COVID is that there are opportunities. One of the first things that we've learned is all of a sudden we've had to treat people at a distance virtually by phone, by text, by email, by Zoom, by Skype, various ways. And guess what? We've now become comfortable and familiar with doing this. And it turns out there's a definite role for virtual health. Cheaper for the patient, cheaper for the system, way more convenient for the patient for sure, convenient for us, more efficient. It can enhance access. In my younger days, I used to do remote clinics way up in northern Alberta, places like Manning, on a lot of the reserves in northern Alberta, and the pathology that you would see was unbelievable. And a lot of it was because people could not get to the big city. And sometimes the big city would be Grand Prairie or Fort McMurray. All of a sudden, we're familiar with remote access. And so we really are able to increase our access and perhaps our volumes as well. So that's one of the things that's come out of COVID. So although face-to-face is important, establishing the relationship's important, once the relationship's established, then yes, indeed, we may be able to manage by a lot of these virtual encounters. We've had to work differently, and we've seen different roles in terms of our health workforce, and it's made us question the way in which we remunerate health professionals. You know, is fee for service, is, you know, volume-based payment the best, or should we be thinking of, you know, population-based payments, of outcome-based payments? Here's a fee in order to look after a group of patients. Can we use nurse practitioners where we thought we could only use doctors? Can we make greater use of pharmacists and other people in the community? So it's making us rethink how we use our health workforce. We heard last week and previously about, and in previous rounds, about virtual hospital, as is run out of the University Hospital here in Edmonton. And we have Norman here with us, which is fortuitous, and the Complex Care Hub in Calgary. Do we really need to put people in hospital, or can we manage in the community? COVID has forced us to do that, and has allowed us that opportunity to actually see, can we manage people out in the community? I must say that, at least in health administration, there's been some skepticism, and I know in the doctor field, there's been skepticism as well. Health administrators say, you know, in a hospital, I can have one nurse for 4 people. In the community, I have to have 4 nurses for 1 patient to provide 24/7 coverage. Well, it turns out that you don't need a nurse there 24/7 for a lot of the people that we look after. The way in which we can provide care through virtual hospital or complex care hub often requires only, you know, an hour a day, a couple hours a day of nursing or community paramedic care. So some evidence is coming out. Turns out that if you're a money person, a return on investment person, that actually it is cheaper in almost all cases to look after people in the community. But I can ask you this, imagine yourself, do you really, if it was you, do you really want to go into hospital? So I've listed here a whole bunch of bad things that happen to you when you go into hospital. One of the things I didn't put in bullet form, but I put in a picture is here. You get to wear one of these high fashion gowns where everybody in the world, every stranger, every visitor can see your butt. But you get things like sleep deprivation, 50% of your nutrition. You get it to be in this noisy room where you don't get to sleep. People are poking you, asking you if you're asleep. You have to share a bathroom. You get our high quality gourmet hospital food. You have to pay for your own TV, you're not in your familiar surroundings. All bad things happen to people in hospitals. So if we can manage people at home in your familiar surrounding with your own pajamas and your own TV and your own Netflix, well, maybe has some advantages. One of the things we've been able to introduce as well is what I call meaningful remote monitoring. Now, remote monitoring has been around for a long time, and what that is usually meant is that, okay, we've got this fancy technology and it will take the person with diabetes' blood sugars and it will send us to us sitting there in Command Central, and we will tell the person how much insulin to take, which is absolutely the wrong thing to do. That promotes dependency. And one of the things we want to promote is independence, self-management. But remote monitoring has changed. We become much more informed around remote monitoring. And today's remote monitoring, the remote monitoring we currently have for virtual hospital and complex care hub is the following. It asks people, how are you doing today? How do you feel? Did you eat? Did you talk to someone? Do you have pain? All of these things that are very, very important to people. And then it might ask about their specific chronic condition. You know, has your weight gone up? Do you have more edema? What is your blood sugar? Yes, it does have those, but it's much more meaningful in how people do and what has impacts on health. And then finally, one of the things that COVID has forced us to do, it's forced us to work together. We've had much greater integration with the social sector, with primary care, and this stress test on the health system of COVID has shown us the soft spots. Turns out we did well with acute care, we did well with ICUs, we did well with emergency, all of that stuff we did well with, but it highlighted our challenges with continuing care, with home care, with people at home. It showed us the soft spots. So I've already alluded to this sort of indirectly and a number of times already, but just to be overt about it, we've known from the last grand rounds that we gave was the importance of social determinants. Many studies have shown us that 80% of health is determined by the social determinants, by housing security, food security, social connectedness. Remember, our study in Edmonton showed us that the single greatest determinant of hospitalization in older adults was their loneliness. So all of these are very, very important to health. And once we deal with these, then we can deal with their chronic diseases. In endocrinology and diabetes, we always teach our students and residents, we say that if a person has good diabetes control and then develops depression, their diabetes will go out of control. And we can give them all sorts of extra pills and more insulin and nothing happens. But if we treat their depression, if their diabetes is, or sorry, their depression is treated without doing anything more, their diabetes will come back in control. What did we just say happens with COVID? Mental health and stresses. So we can anticipate deterioration in chronic disease. We deal with the social factors. Chronic diseases will become much easier to control. And yes, it's the chronic disease that leads to the coronary artery disease, to the heart attack, to the stroke, to the cancer, and so on. But until we deal with the social factors, we won't be able to deal with the medical factors either. And what has COVID done? Well, it's forced us. This is sort of the metaphor of what things were like pre-COVID, metaphor of what they're like after. We have 25,000 not-for-profit and volunteer and charitable groups in Alberta. COVID has forced us to work together, organize our transportation, food security, housing security. So that's been one of the benefits. And this is just an example of, for seniors, Alberta Core. It's a function that brings together all of the not-for-profits and volunteer groups so people can access resource. This is just an example of all of the resources from across the province that you can access if you are in need. It brings the organizations together so they can coordinate their activities. We've been able to have 211 as that single point of access for anyone in Alberta who has a social need. Just call, text, or email 211 and your social needs will be addressed. Well, one of the things that we haven't done, we haven't been good about asking about social needs, but now that we know when we ask about them, we can actually do something about it. We have 211, we have Core Alberta, we've organized the social sector. And just to remind you, Connect Care, front page, bottom left corner, social determinants. So please use that box because we can do something about it. So that brings us to the end. You know, COVID has caused a lot of challenges. Some we just couldn't do anything about, but just acknowledging and knowing them about them will help us understand and manage chronic disease now. A lot of the things that have come out of COVID will enable us to better manage chronic diseases on a go-forward basis. Hope that this has provided us some insight into chronic disease management, the challenges that COVID has caused on physical health and on mental health, of course, as well, and that we can use this information to better meet the needs of our patients. So I'll finish there, be happy to answer any questions.
Thanks, Richard. That was excellent, and exactly the kind of overview that I think we all needed in order to prepare. So I'm going to start with our CEO's question here. Dr. Yu is just asking, given the response that Sweden decided to undertake, where they chose not to do some of the same containment strategies, what are your thoughts and what is your prediction in terms of what you suspect their outcomes are going to be with relation to chronic diseases?
That's a great question. If there's been less emotional impact, psychological impact, mental health impact, then we would anticipate, and this would be, I guess, a real life experiment, perhaps a better control of the chronic disease, less incidence of new chronic disease, perhaps a quicker return to control of chronic diseases. So it'll be interesting to see what their experience is. Interestingly, the other countries that got on top of COVID, and maybe we in Alberta can include ourselves in this, got on top of COVID very quickly and very aggressively. They were able to keep people isolated for a much shorter period of time. I'm thinking of Taiwan, for example, or even South Korea. And so it's that short-term pain for long-term gain. Whereas if we sort of stretch things out, the longer we went with the social isolation and all of the consequences that occur from that, we might see that higher incidence of chronic disease or poorer control. So it'll be interesting to see what might happen as a result. I guess it's a natural experiment.
So the next question is I'm going to ask is really around technology. So, this is a much different sort of response in 2020 than we've had compared to, previous epidemics, at least with SARS and other related illnesses. So what do you think has been, or is there even any evidence base behind the impact of having technologies like Zoom and other things where we're much more able to do face-to-face either visits or even medical visits and so on? Do you think that potentially may have had any impact at all? And is there any evidence to support that it could have been positive, or doesn't matter?
Yeah, no, also really, really good question. I think we will have learned from COVID, and actually we'll have probably, as many things with COVID, we'll have learned more in a few weeks than we probably would have learned in our standard way of doing things over a few years. And I think it will become very apparent to us, and we have alluded to this as well, that there's a lot of situations where technology is very useful and will really improve our care in terms of things like access. And we often forget that we bring people down from Fort McMurray to Edmonton to tell them, yeah, your TSH is normal, go home, but they've had to take 2 or 3 days off work, pay for their own travel, and so on. Now we can deal with that in 2 minutes instead of 2 days. So we're going to have those sorts of beneficial impacts, but there's other situations where we now know that people really do need that face-to-face. So I think that will become clear to us, and we will be able to sort that out. There already is evidence that when you are able to use technology appropriately, it does have that benefit because you are providing better access and more immediate access as well. We know that delays in care lead to poorer outcomes. And so now, for example, in Kaiser, if the patient emails you, you're expected to respond within 2 hours. But we have things, some of the programs now in Edmonton and Calgary around Specialist Link, for example, that provide this, response within a couple hours to primary care's questions for advice. So all of that's as a result of technology. So there's a lot of good, as I said, that will probably come out of this, and we will have learned more, as I say, in 10 weeks than we would have learned probably in 10 years of doing it, previously. So, a bit of the silver lining, and we often hesitate to say that, but it's one of the goods I think that will come out.
In a lot of situations, we've learned very quickly. Yeah. There's another question around, I think this is interesting. What do you think touching with gloves has a similar impact?
Wow, that's a great question. I don't know. As I say, we never realized the importance of touch, and of course, in the Me Too era, everybody becomes very, very afraid of touching. Um, just one anecdote, but there's no question that there is the benefit. It's, I often say, so on date night, with your sweetie, whoever that is, do you want to be across town doing it by Zoom, or do you want to be there, face to face, at the restaurant holding hands? And I won't go any further down that route, but you get the point. Touch is important, and we've been told, patients have told us, no question that they appreciate it. And I showed one slide that said, we appreciate face-to-face contact, but interesting, I'll give you another anecdote, is that I was fortunate enough, a number of months ago, the LPNs had their annual convention for the province, and there was over 300 in person in the biggest meeting hall you could have at the Westin Hotel in Edmonton. And I was one of the speakers, and I was getting onto this physical contact touch business, and I got on my rant about how we're not allowed to touch anymore. And I said, people just like to touch. They love that. Patients tell us, when the nurse gave them that back rub at night, they couldn't appreciate that more. Anyway, on this business of touch, when we talked about it and I expressed my opinion that touch was a good thing, all 300 and some, the whole room stopped. 300 and some LPNs got to their feet and applauded the concept of their appreciation for the need for touch. So they appreciated the benefit from touch as well. So I think we both benefit as well. And as you say, if you want to get really scientific about it, we can put an indwelling catheter in. The minute you touch somebody, oxytocin is released. It's sort of cool that we get this whole neurohormonal response from touch. Whether it happens with gloves or not, I don't know.
So I think this one is a little bit sort of seeing into the crystal ball, but do you have a sense at all in terms of whether or not Alberta Health or government sees the benefit of the virtual care delivery model and some of the benefits that you talked about, and whether this will continue on into the future, or, again, crystal ball type question. Do you have any insights into that?
Yeah, that's great. One of the things, another benefit, an invisible benefit from COVID, is that, at least in my area within AHS, I spent most of the COVID career working with other government ministries, with health, seniors and housing, community and social services, and with culture and multiculturalism, status of women, which is the ministry that's responsible for volunteers, and all of them also work together, and everybody in those ministries, in the volunteer sector, in AHS said, the way in which we've worked together is great. The new way of doing things, we can't go back, to the old way of our solution to everything is put people in hospital. So I really think that there is going to be that support for things like virtual hospital complex care hub and doing things differently. Everybody has expressed that desire, whether it's volunteer, government, AHS.
I think we'll end it on this, but with this last question. Do you have any suggestions, recommendations, thoughts about the next wave? We know that there are going to be subsequent waves before the vaccine, or a definitive cure, I guess, coming into the future. Do you have any thoughts about how we deal with the second wave?
I think we use the learnings from the first wave, and again, good question. I think one of the things would be to get on top of it quickly. Sort of, it's again the short-term pain for long-term gain. Get on top of it, squish it, squelch it out, so that we can get back to normal as quickly as possible. But again, understanding what the impacts are going to be, I think we will be much better set up for care in the community for the next wave. So in a way, we're almost already prepared in that regard. So if it comes, I think we'll be better set up, and we'll be aware of the sorts of things that we need to do, which is what hopefully we've talked about this morning.
Thanks, Richard. We've got a whole bunch of comments in the chat box. That was an excellent presentation and really timely. So thank you so much. I just wanted to make a quick announcement that next week we're going to have an international guest presenting medical grand rounds. Dr. Andrea Coserizza from the School of Medicine at the University of Modena in Italy will be presenting on immune changes during COVID-19 pneumonia and sharing the Italian experience. So hopefully you'll be able to join us. Have a great weekend, everybody. Thank you.